My vision for the Lineberger Geriatric Oncology program is to address several issues. One is educating our physicians and medical staff colleagues concerning geriatric cancer issues. For instance, the average age of cancer in the United States is 67, and yet our view of cancer from perhaps looking at TV, looking at the media is much younger. You never see an older patient in an advertisement. So one is to educate people on the scope of the problem, the fact that 60% of cancer survivors in the United States are 65 and older, and the fact that because in the United States and many of the Western countries people are living longer, there are going to be more and more cancer patients as we age. So education is key. And then research. A lot of our treatments that have proven so effective in reducing the mortality rates from cancer have been tested on younger people. So a lot of, for instance, of the chemotherapy regimens that we've tested, we don't really know about how an 80-year-old woman would do with that regimen. And what we don't want to do is take someone who's functional and perhaps living at home by themselves and give them chemotherapy and then have them become a dependent person and need nursing home care or other care. So we need to learn about that. So our research will focus on giving people the best quality of care, but doing what's called a comprehensive geriatric assessment for many. So those people who are on the borderline because of other non-cancer illnesses, we will be able to predict in the future how they will do with treatment. And I should say the Lineberger has some incredible, not just clinical care, supportive care, our new program that's being built by Dr. Rosenstein, but with Dr. Ned Sharpless is looking at some of the key genes related to aging. And the longer we live, the more likely we are to get cancer. So there's an interrelationship here. And the longer we live, and if we get cancer, the longer we're going to be a survivor. So there's a lot of opportunities for great research here as well. And then the last thing would be the survivorship. You know, frequently someone has cancer and they come into the doctor and cancer is the dominating diagnosis. But really what may be important is the patient's blood pressure, if he or she is falling down 2 or 3 times at home. And we get so focused on cancer because it's such a powerful word, we miss the other components of caring for the patient. So a lot of this will be working with our survivorship group so that those patients we treat successfully, we can take and address their other illnesses as well with primary care colleagues, gerontologists, etc., to make their lives better as well as longer. I look at the Geriatric Oncology program as a program that will be like a matrix. For instance, rather than have a separate silo of doctors just doing geriatric oncology, I know that we already have many doctors at the Lineberger that are interested in older patients with cancer. For instance, Dr. Goldberg, the Director of Hematology Oncology and our Associate Director for Research, clinical research at the Lineberger, has done a lot of work on older patients with colon cancer. My view is to look like the Marines for a few good men and women in each discipline. Lung cancer, colorectal cancer, gynecologic oncology, hematology, and to try to get a champion in each of these areas. And so I look at it as a collaboration of teamwork among other members of the cancer center and not really a separate, like a breast cancer program where you focus on people who all they're going to do is breast cancer. Everybody's involved in geriatric oncology because that's where the patients are. So it requires, I think, a little bit different strategy to be successful. I got interested in breast cancer very early in my career and probably came into geriatric oncology through the back door. I had a wonderful mentor and actually chief of medicine named William Hazard. He was actually at Wake Forest and he's now semi-retired, although he'll never retire, out at Seattle. And he asked me to do a project perhaps 15, 20 years ago with one of the residents focusing on breast cancer and older women. And we looked through our records of clinical trials we had done, and probably due to our naivete, we never put an upper age limit on the patients. So many of the clinical trials, even National Cancer Institute trials in the 80s and early 90s, had an age limit. It would say patients between 18 and 65. And it was totally ageism, in my opinion, in retrospect. but we were able to look at our data, and we had a lot of women in their late 60s and 70s who were actually on trials of cutting-edge treatment. So I wrote the paper with the resident. She is now a medical oncologist in, I believe, Texas, and it was accepted to the Journal of the American Medical Association. Well, I was very pleased, but the downside was I knew nothing about geriatrics. So I started getting calls from people who did about their patients with breast cancer. And so I figured I had to learn a lot about this. So I, over the years, have been done on-the-job training, and fortunately have had wonderful colleagues, and now have kind of morphed in with a group of people who are very interested in geriatrics and cancer and blood disorders, and it's been a mutual learning experience, and I've just loved it because I love the older people. They have great stories to tell you. They have different levels of anxiety than younger patients. If, let's say, a younger woman gets breast cancer in her 40s and she's got children and she's trying to hold a job, the issues in her life are different than an older person who may have grandchildren and is not trying to raise a family. These days she may be working, but they're a little different. All of us want to survive. I mean, I don't think that there's any less will to live and beat cancer in older people than younger people. But I find it's delightful to listen to their stories and issues, see how they cope with things. And I must say I've learned as much from taking care of them and have some great stories to tell as they've ever learned from me. So it's just been fun, and I've come to really enjoy it. And I think a lot of geriatricians will tell you that. Our older people have so much wisdom and so much to teach us about life, medicine, dealing with illness. It's very special. UNC is has a fantastic cancer center. It has research that spans from the most complicated genetic studies in the laboratory to some of the best health policy research in the United States. It also has an outstanding geriatrics division. It has a special aging center. It has a Hartford grant looking at training people in geriatrics, and probably the best, it has wonderful people to work with. So looking at all of this, and with the generosity of the state, looking ahead and giving such great support to the Lineberger to build cancer programs and do research, I was able to come here and hopefully with not too much convincing, have Dr. Earp, Dr. Goldberg, and many others willing to underwrite and get a geriatric oncology program going. So I think this is a perfect place. We have great players. We have collegiality. It's very easy to work here. Very open door, no big silos or barriers to working people, and all the talent is here. And so I think it's going to be successful. I think it's people are aware of the issues here, and I think that this cancer center has had remarkable growth, and is just one of the best cancer centers in the United States, in my opinion, the best to do this.